times, lower costs, and avoiding the possibility of donor site morbidity. However, it has become a more popular procedure in recent years. Unfortunately, surgical site infection is the most common complication of tissue expander breast reconstruction. This can result in multiple hospital readmissions, increased costs to the healthcare system, delay in treatments, emotional stress to the patient and their families, and can ultimately result in implant loss and reconstruction failure. Currently, there is no consensus on the appropriate prophylactic antibiotic duration to prevent surgical site infection in these patients. ASPS's guidelines were last updated in 2013, which dictate perioperative antibiotics at least 60 minutes prior to incision time and discontinuation after the perioperative period if no drain is present. However, they leave it to the physician's discretion if drains are present to continue antibiotics or not, which typically is a oral discharge antibiotic regimen for 7 to 10 days or until drain removal. And this leads to some discrepancies among providers in regarding antibiotic prescribing practices. Additionally, there's a lack of research regarding microorganisms across different antibiotic protocols, and the rate of implant loss must also be investigated. So the goal of our study was to identify if a prolonged antibiotic regimen reduced the incidence of infection with highly virulent organisms, to compare the bacterial profile across 2 different protocols, and to determine if duration of prophylactic antibiotics affected the rate of implant loss in these patients. We performed a retrospective chart review of patients who received tissue expander breast reconstruction between 2001 and 2018, compared demographics, and we included surgical site infections that required inpatient management prior to stage 2 of reconstruction. Those that occurred after stage 2 were excluded. We defined highly virulent organisms based off of escape pathogens. These are classically highly pathogenic organisms that are typically lead to multi-drug resistant and can be very difficult to treat. We define implant loss as the removal of a tissue expander without immediate replacement. So 660 patients underwent tissue expander breast reconstruction at our institution between 2001 and 2018, 85 of whom developed a surgical site infection requiring inpatient management prior to stage 2. Group 1 had 56 patients that received less than 24 hours of perioperative antibiotics and an oral discharge antibiotic regimen. 64% of these patients developed a culture-positive surgical site infection. Group 2 had 29 patients who received less than 24 hours perioperative antibiotics only, and 83% of which developed a culture-positive SSI. When comparing these 2 findings, this was not to be significant, although it was approaching at 0.076. There were no significant differences in the demographics between our 2 groups. This was age, BMI, tobacco use, preoperative radiation and chemotherapy, type 2 diabetes, and ADM usage. So when we look at the profiles between our 2 groups, there was a significantly increased incidence of gram-positive organisms in group 2 who received perioperative antibiotics only, as well as Staph aureus. Interestingly, the Staph aureus was the most commonly grown bacteria in both groups. Pseudomonas was trending upward in group 1 as well, although this finding did not reach significance. And when we looked at highly virulent organisms as a whole, there was no significant difference between our 2 groups at 42.9% in group 1 versus 58.6% of patients in group 2 with a p-value of 0.168. When we look at the complication rates for our patients, they were also very similar. So the development of hematoma, seroma, skin necrosis, and wound dehiscence in both of our groups were not to be significant. And interestingly, the rate of implant loss in both of our groups was almost identical at 62.5% in group 1 versus 62.1% in group 2 with a p-value of 0.969. So our study showed that prolonged postoperative antibiotic use did not provide additional protection against overall highly virulent infections. The rate of implant loss in our groups were nearly identical, around 63%. We continue to recommend to practice antibiotic stewardship to avoid overuse of antibiotics. However, we know that our study was limited by its retrospective nature. Going forward, we think that there are further studies requiring multi-center cooperation may be necessary to develop evidence-based guidelines for this practice. Thank you.
Great. Thank you, Caitlin. Next, we'd like to introduce Barada, speaking on complications of breast reconstruction following bariatric surgery.
Okay. Can you guys hear me okay? Okay.
Yes, great.
So my name is Mike Brada. I'm a fourth-year resident in the integrated program at Dartmouth-Hitchcock Medical Center. I'll be presenting our discussion, complications of breast reconstruction following bariatric surgery. This was actually done at Mayo Clinic in Jacksonville, Florida, when I was a resident there for my first 2 years as a general surgery resident. Next slide, please. Can you go, there you go, perfect. So there's an increasing rate of obesity in the U.S. population over many years now. With that increasing rate, there's been an even more increasing rate of patients seeking bariatric weight loss surgeries, including Roux-en-Y gastric bypass, sleeve gastrectomy, and other operations. And with that, we thought that there would probably be a also increase in the amount of patients undergoing some type of breast reconstruction surgery after bariatric surgery and possible massive weight loss. We were interested in looking at this population in breast reconstruction because we believe that there can be some technical challenges to these patients in their reconstructive scenarios. We had questions about tissue integrity, wound healing problems, massive weight fluctuations, changes in their body habitus, nutritional status, poor vitamin regimens, poor nutritional labs. So we thought that all these things could factor into having potential problems for these patients in the postoperative period after reconstructive operations. Next slide, please.
Sorry.
April, can you hear me? Oh yeah, perfect. And so when we thought about these patients, we looked at different things that we thought would be important to them. This is just some of them, you know, morbidity, mortality, major and minor complications, reoperations, readmissions, what type of implant or what type of reconstruction they're having, autologous versus an implant-based reconstruction, the cost to the patient of readmissions and reoperations, their satisfaction with their outcome of the surgery, how they believe it looks with their body habitus or their body type. So these are the different things that we thought about when we were going forward with this study. Next slide, please. Our methods included a retrospective review at Mayo Clinic Jacksonville from 2007 to 2019. We included females 18 years or older, history of breast cancer, and a history of bariatric surgery. The breast cancer and reconstructive surgery needed to occur after the bariatric surgery. If they had bariatric surgery after the reconstruction, we excluded these patients. We looked at, our primary outcome was overall complications, major versus minor. Major was considered any reoperation, unplanned or readmission in 30 days from the initial operation. And then minor ones included things like seroma, local wound infections, wound dehiscence. We also looked at variables including BMI, age, comorbidities, smoking and alcohol use, type of reconstruction that was performed, preoperative chemotherapy and radiation, time between their bariatric surgery and reconstruction, and the complications that did occur. Next slide, please. Our cohort was small. Unfortunately, we identified 21 patients in total from our review. We had to exclude one of them because they had their reconstruction prior to the bariatric surgery, so we couldn't look at their weight loss before surgery for the reconstruction. We had the rest of the cohort, we had 8 autologous patients. 1 was a deep, 4 were latissimus dorsi flaps, and 3 were trams, and then we had 12 implant-based patients that included tissue expanders to permanent implants. Of these patients, the most common bariatric procedure was a Roux-en-Y gastric bypass at 75%. Then it was laparoscopic sleeve gastrectomy at 15, and then gastric banding. Next slide, please. These are just some of the characteristics we found in these patients from our review of the charts. There was 11 former smokers, 7 patients that never smoked, and 2 that were actually current smokers during their reconstructive operation. 12 of them had hypertension, 8 had diabetes, 7 had pre-reconstruction chemotherapy, and 8 had pre-reconstruction radiation therapy, and 7 had prior abdominal operations. Next slide, please. So our outcomes, briefly here, the pre-bariatric surgery mean BMI was found to be 43 in this cohort. Average age was 51 during their surgery. At reconstruction, their mean BMI was 29.7, so there was collective weight loss in this group. Overall, the number of complications that occurred were high. 16 of these patients had some type of minor or major complication. 5 patients had major complications. All of them were readmissions, with 3 of them having reoperations for wound healing issues or infections, and 15 had minor complications. The most common complications found for the minor included fat necrosis at 5 patients, followed by skin necrosis and seroma at 4 patients each. Next slide, please. We believe that from our small study that, prior significant weight loss in the breast reconstruction patient population can be very challenging. Our outcomes showed a high complication rate. We're not sure that it's prohibitive, though, and we think that it's imperative that we provide preoperative counseling to these patients and educate them that there could be a potential higher risk of surgical complications post-op, and this may be due to the weight loss that they had, their nutritional status, other comorbidities. Limitations to our study included a very small sample size. It was a retrospective review. It was data from a single institution. Going forward, we're actually applying for an IRB here at Dartmouth-Hitchcock Medical Center to hopefully increase the number of patients in this study and get a greater power, and we can further stratify the data and really see if there's any correlation to any of these variables that we kind of looked up in our first study. So we want to get a larger cohort from another academic center. We want to assess additional markers for postoperative complications, potentially get insight into complications in geographically different patient populations if we can get enough patients, and really look for indications for what type of procedure would be best for a patient, whether it be autologous versus a implant-based operation. Is it preoperative management that really matters in these patients, and making sure that their labs and their nutrition are up to par? And is there a difference in time between bariatric surgery and reconstruction that we can elucidate and see if there's a specific time that we should be operating on these patients? So these are all things that we hope to further look into as we go into our new study at Dartmouth-Hitchcock and get a bigger cohort here. Next slide. And that's it. Thank you for your time. I appreciate allowing us to talk about our research.
Thank you very much. Our next presenter is Masa Taskinduce, presenting on the effects of obesity on adipose stromal cell biology contributions to breast cancer risk, and he or she will be presenting from Duke.
Good evening, everyone. Thank you so much for the introduction. Like you all heard, my name is Masa Taskinduce. I'm a third-year medical student at Duke, and I'll be talking a little bit about the impact of obesity on breast adipose stromal cell biology and the potential contributions to breast cancer risk in that realm. So just starting off with some background information, we know that obesity in women significantly increases their lifetime risk of developing breast cancer. Additionally, senescent cells are associated with multiple disease states, in part due to their secretion of inflammatory cytokines such as interleukin-6 or IL-6. Our lab previously demonstrated that BRCA1 mutations, which are associated with increased triple-negative breast cancer risk, directly impact adipose stromal cell biology, or ASC biology, as I'll refer to. This results in DNA damage, cellular senescence, and the secretion of additional inflammatory cytokines. So, in the current studies that we did, we investigated the hypothesis that ASCs from obese women are senescent and that they secrete senescence-associated inflammatory cytokines, namely IL-6. And these may contribute to breast cancer by acting in a paracrine manner on the breast epithelium. So working with that hypothesis, one of the first things we did was to isolate ASCs from the stromal vascular fraction of adipose tissue obtained from women undergoing breast reductions. These were women who had BMIs either greater than 30 or under 27. So in order to assess whether these cells initially were senescent, we measured that senescence by using a beta-galactosidase assay, which stains blue. And as you can see in these images of the stained ASCs above, on the left is ASCs from a patient with a BMI of 26.5, and on the right are ASCs from a patient with a BMI of 38. Now, these images demonstrate that there's definitely increased beta-gal staining in the higher BMI or the BMI of 38 ASCs compared to the cells or the ASCs from patients with a BMI of 26.5. So we then wanted to assess how these senescent cells could be contributing to their environment, and specifically whether they were secreting senescence-associated cytokines. So to address this, and to address this part of our hypothesis, we collected conditioned media for 72 hours from the same ASCs we had isolated from these patients, and conducted ELISAs to check levels of IL-6 and IL-8. So as you can see, women with BMIs above 30 in both the assays checking for IL-8 and IL-6 showed significantly higher concentrations of those cytokines when compared to their lower BMI counterparts. So the next step in this process was to follow up on that last finding. So seeing that high BMI ASCs are secreting high amounts of IL-6, we wanted to examine the ability of this recombinant IL-6 in promoting STAT3 signaling and senescence in ASCs from low BMI patients. So to do this, we pulsed these lower BMI ASCs with 10 minutes of recombinant IL-6, plus or minus soluble IL-6 receptor, which is labeled SIL6R there. So after pulsing them, we took equivalent amounts of nuclear protein extract from these cells and examined them through Western blotting. So here we specifically were blotting with phosphostat-3 antibodies, and notably you'll see in that kind of last column that that only with the addition of both IL-6 and the soluble IL-6 receptor do you see that phosphorylated STAT3 show up. Which essentially indicates the activation of trans IL-6 signaling and activation of that STAT3 pathway in ASCs that were previously low BMI or normal. And of note, this pathway is strongly implicated in inflammation and other pathological processes. So, ultimately our results together demonstrate that ASCs from obese women are senescent. They secrete senescence-associated cytokines, and specifically those that can act in a paracrine fashion on the breast epithelium. And ultimately, promote cell behaviors that are associated with breast cancer. And ultimately, determining how obesity impacts ASC biology and how that biology may contribute to breast cancer will provide an important foundation for developing novel, potentially ASC targeting therapies to reduce breast cancer mortality. And thank you so much for this opportunity. And thank you to my lab and my team.
Wonderful, wonderful job, Masha. Thank you. The next paper is The Risky Positions of DIAP-FLAP Breast Reconstruction. And this is going to be presented by Kristen Harless out of Rochester.
Hi, thank you for this opportunity to present our work here at the Mayo Clinic in Rochester. We're talking about the risky positions of the DIAP flap in breast reconstruction. This was a pilot study. It's no surprise to those who are watching this that autologous breast reconstruction is a long operative procedure that requires microsurgical techniques, typically requiring a 2-surgeon approach here at our clinic. It also requires sustained awkward or uncomfortable positions in order to effectively access our perforators, harvest the flap, and reconstruct the breast. The goal of our study was to identify surgeon postures during the DIAP flap and to identify those parts of the procedures where we're sustaining awkward positions that are associated with increased risk of developing musculoskeletal disorders. We divided our surgery into 3 main parts: harvest of the abdominal flap, exposure of the internal mammary vessels, as well as the microvascular anastomosis. In order to assess our positions during the surgery, we placed inertial measurement units on the 2 primary surgeons. These were placed on the head, back of the torso, and both of the upper arms. And this allowed us to quantify our postures during the DIAP procedure. The postures were then translated into the rapid upper limb assessment, which takes the mean angles of the surgical postures and scores it on a scale of 1 to 4. Scores greater than 2.5 were considered at risk of developing musculoskeletal disorders. We did this for 5 bilateral DIAP flaps. The average length of our case was 467 minutes. Here are the primary results. You can see that the neck and back exhibit higher joint angles and are at greatest risk during the chest dissection and abdominal flap harvest. Specifically, looking at the neck angles, the average risk score of greater than 2.5 was found as in the chest dissection as well as the abdominal flap harvest. Notably, when we were doing the anastomosis using an operative microscope, our risk scores normalized. Looking at our torso angles and the angle of which our upper back was at risk, we were below average for the chest, abdominal flap, and as well as the anastomosis. If we did look at it by the time we spent in those awkward and uncomfortable positions, it's no surprise that when we were using loop magnification and lights or headlights, that during the abdominal flap service, about 68% of the time, our neck was in a risky position, which translates on average to about an hour and a half. For our chest dissection exposure of our internal mammary vessels, our neck was at a risky position for 1.3 hours. But then again, when we were under the operative microscope, everything seemed to normalize. Looking at our upper back, again, no surprise that when we're doing the abdominal flap harvest, we're bending over trying to evaluate the perforators. And on average, that's 1.6 hours in a risky torso position, and only a half an hour when we're doing the IMA exposure. In conclusion, deep flaps, it's no surprise that we've all woken up after doing a deep flap with neck, upper back, and shoulder pain. But being able to identify where we're having to sustain those positions will then allow us to identify strategies to reduce our risk for sustaining those procedures in the future. This will hopefully allow us to have long, prosperous careers in the future. Thank you.
Thank you, Kristen. I'm glad I don't have a deep flap tomorrow after that. Last in this group, we're going to hear from Jocelyn Marquez from Stony Brook, talking about demystifying systemic anaplastic large cell lymphoma after breast augmentation, separating fact from fiction.
Hi, can everybody hear me? My name is Jocelyn Marquez. I'm a general surgery resident at Stony Brook University Hospital. Thank you for this opportunity to present our talk. We have nothing to disclose. Breast implant associated anaplastic large cell lymphoma is a distinct T-cell lymphoma involving the capsule or effusion surrounding the breast implant. The first case report was published in 1997. The lymphocytes consist of medium to large sized, and they can progress to infiltrative disease with mass aggregation in more advanced cases. In 2011, the FDA confirmed that textured implants can cause a reform of ALCL. And in 2016, the World Health Organization organized the classification of lymphomas to incorporate BIA-ALCL. There's about 700 known cases worldwide, and that number continues to grow as we begin to understand this disease process more and more. It's estimated that about 1 in 1,000 to 1 in 30,000 women who have textured implants are at risk. Textured implants have been largely affiliated with this disease process, and the theory is the higher surface areas of textured implants can increase the risk of the development of BIA-ALCL. There's many theories behind it, including driver mutation or genetic predisposition, especially in patients who may present with bilateral disease. Other pathogenesis theories include chronic inflammation of T-cell stimulation leading to severe reactive dysplasia, degradation of the silicone shell that may lead to erosion of the implant, development of antigens, and expansion of the T-cells. Also, other theories included subclinical biofilm with low-grade infection. Here we've described a unique case of systemic CD30 positive, ALK1 negative, anaplastic large cell lymphoma that caused pain and swelling around a textured implant. This patient is a 44-year-old female who present with right arm swelling, large right axillary and mesenteric lymph adenopathy, and enlarged right pectoralis muscles. She had a recent diagnosis of ALCL with her right breast mass concerning for BIA-ALCL. Of note, her past medical history was significant for placement of a textured implant in 2002 and a family history of breast cancer in a paternal aunt. Her vital signs were unremarkable on physical exam. Notably, she had right erythemic skin changes to the affected side. There were no palpable masses, no nipple discharges. However, her axilla was full and matted and tender, as seen in the picture above. In comparison, the left side, the axillary area showed no fullness or masses or skin changes. Right axillary biopsy was performed, where demonstrated ALCL, ALK1 negative, with large neoplastic cells and abundant cytoplasm, strongly positive for CD30 positive. A mammogram was performed, which we demonstrated edematous right breast with some edema with the left breast and extensive right lymphadenopathy. A CT scan, we demonstrated the supraclavicular, mediastinal, and right mammary lymphadenopathy, massive right axillary lymphadenopathy, and considerable mediastinal lymphadenopathy. Enlargement of the right pectoralis muscle, possibly due to infiltration and persistent right upper extremity and chest wall bulging of the pleural soft tissues. A PET scan showed hypermetabolic activity of the right chest wall and cervical lymph nodes in the mediastinum, consistent with history of anaplastic lymphoma. She began chemotherapy shortly after. Later on, she went to the operating room with plastic surgery for bilateral capsulectomies and removal of the saline implants. Intraoperatively, the right affected side demonstrated large amounts of turbid periprosthetic fluid with significant capsule thickness compared to the left. Pathology of the right breast capsule showed only small amounts of lymphocytes and benign skeletal muscle with benign fibroadipose tissue. Here is a gross picture of the gross specimens from the case. Picture here is the right breast capsule of the affected side, and here's the left breast capsule of the affected side with the corresponding implants. Cystology of the specimens demonstrated for the right breast peri-implant fluid had cloudy yellow fluid. However, it was negative for malignancy. Apical metaplastic cells with foam cells were seen, which is consistent with fibrosis changes. Post-operatively, she was seen post-op week 6 with her incisions clean, dry, and intact, no signs of a hematoma infection. The breast asymmetry you see was likely native prior to her implant was replaced. Here we present a case report of a patient with systemic ALCL involving her textured implant. However, it did not directly cause BIA-ALCL. We believe that the systemic ALCL likely triggered an inflammatory response heightened by the presence of the textured material. There are many causes of late onset peri-implant seroma formation. However, physicians and surgeons should maintain a high index of suspicion for BIA-ALCL, as we did here. In conclusion, we should continue to advise patients plan for insertion of textured implants, especially for the risk of BIA-ALCL. Plastic surgeons should be aware of the various ways implants may be involved in an inflammatory removal process, and further studies are needed to further investigate the relationship. Any reconstruction should be delayed until the systemic ALCL has been addressed. These are my references. Thank you for this opportunity to present our work, and a special thank you to my research team and my PI, Dr. Bowie, for this opportunity to be part of this project. Thank you.
Thank you, Jessely. That was fantastic. So we're running a little bit behind, but I think we have time for probably at least a question for each of the presenters. Caitlin, so based on your research, are you going to send patients home on antibiotics? What's going to be your plan? And if you are sending them home on antibiotics, or what are you going to send them home on, and for how long?
Thank you. That's a great question. So this area of research has been something of interest for Stony Brook for quite some time. This is kind of a follow-up study. We've had a previous randomized trial that showed no significant differences in the rate of infection. So in conjunction with that trial and our study showing that antibiotics didn't provide any protective effect against infections or the rate of implant loss, I would choose to discontinue antibiotics after the perioperative 24-hour period.
Great. Kristen, there were a number of similar questions floated on the chat, and that was, did you account for surgeon height in your study, and also bed height too? And then the other follow-up question that would be, were these surgeries delayed, or did you have to work around the breast surgeons and where they wanted the bed at a certain height?
Yeah, great question. So the two of us who wore the IMUs are of similar height, and we had control over the operative table height as well. They were all delayed deep reconstructions. We did not have to work with the breast surgeon.
All right, I can have a question for Masa. I think there's a question in the chat room, and I'll check on that in a sec. Actually, I'll just go off the top of my head based on what I read. There's a question as to whether or not there's a thought about the effect of IL-6 on, I think, ALCL.
So, I think in the literature I've gone through and with our familiarity, I haven't seen any direct causal links or correlations with that specific trans IL-6 signaling pathway in ALCL. Although, if chronic inflammation is implicated in that process, it definitely would be something worth studying and looking into.
Okay, and just to follow up real quick, I'm always thinking about clinical implications of your findings. Let's say you were able to understand this pathway a little bit better. Is the idea that patients who are of a higher BMI would be treated and are high risk for breast cancer would be given medications prophylactically to block this pathway, or are we thinking of adjunctive treatments for patients who are of a higher BMI who have cancer, breast cancer?
That's a great question. I think a little bit more research and a little bit more, studies need to be done to kind of assess whether breast cancer initiation or progression is specifically more being targeted by these processes. But, there are, anti-cytokine drugs like tocilizumab is an anti-IL-6 drug. So potentially that kind of therapeutic target would be something to look at down the road. Now, I think you bring up an excellent point of whether that's prophylactic or whether that's part of someone's treatment. I think further studies probably need to kind of elucidate between those two.
Thank you.
Okay. All right, should we move on to the second session?
All right. I think I'm introducing the next presenter. This will be Mazen Diab, presenting on a physics-based biomechanical model to help predict outcomes after reconstructive surgery of the female breast. And I am guessing this will be from MD Anderson.
Yeah, good evening, everyone. My name is Mazen Diab. I am a lecturer at the University of Texas at Austin. And this work is in collaboration with plastic surgery department at MD Anderson Cancer Center. So thanks for the organizers for giving me a chance to present our work on developing a physics-based biomechanical model to help predict outcomes after reconstructive surgery of the female breast.
And Mazen, just a quick second. We don't see your slides quite yet.
Oh, okay. I'm sorry. Okay. Okay.
Mazen, you are a co-host. You just need to share screen. There you go.
Yeah, I apologize. I think I missed that part. Okay, do you see my slides now?
Yes. Yep.
Okay, thank you. So to start off with a background, so as you all know, surgery is currently the primary treatment for patients with breast cancer, with number of patients choosing to reconstruct their breast after surgery is on the increase. There are several options for reconstructive surgeries that include autologous and implant-based reconstruction. However, predicting the outcome of these reconstructive procedures is not always possible. So the ultimate goal of reconstruction is to create a breast that is symmetrical with the remaining natural breast. However, this is not always possible, especially after the first reconstructive surgery, where on average, a patient may need 2 reconstructive surgeries to obtain the desired shape, which adds to the psychological and physiological hardship that a patient is experiencing throughout her treatment. So our overarching goal is a decision support system that helps patients choose in consultation with their surgeons a breast reconstruction surgery that best fits their need and expectations. So at the core of this decision support system, a biomechanical model that can simulate the outcome of reconstructive surgeries. So the framework of this, our framework consists of three main parts. The first part is characterization of mechanical property or elasticity of breast tissue. The second part is construction of three-dimensional 3D geometric model of the breast. And the third part is calibration of our biomechanical model using a tilt table and 3D images at MD Anderson Cancer Center. So for characterization of skin elasticity, we have conducted mechanical tests on skin tissues freshly harvested from patients at MD Anderson Cancer Center. So what we do here, we mount our skins on a bulge device, and then we inflate the skin while measuring the response of the skin as a function of the pressure. So what I'm showing here to the right is the skin response under pressure for specimens obtained from different subjects. So the key message here I want to emphasize here that each curve here represents a specimen obtained from different subjects. So it's very clear here that the inter-patient variability is significant. So there is no there is no one elasticity number that fits all. So every patient our subject has a different skin elasticity. Then we can use simulation and optimization to quantify the mechanical property for skin tissues, which are tabulated in this table here. As for geometric modeling, we start with using CT scans or MRI scans for patients either in supine or prone. So here I'm showing the case for a patient in supine position, where through segmentation, we can get the 3D pointy cloud for the pectoralis muscle, and then for the front surface, then using geometric modeling software, we can construct the 3D model, geometric model for the patient at MD Anderson Cancer Center. So now we have constructed a 3D model from the CT scan in this case. However, CT scans do not tell us anything about the distribution of the mechanical forces throughout the body due to the gravity loading for the patient, for example, in supine position. And this is needed for the accuracy of the biomechanical model. So to overcome this, we have one or two options. So either you have to predict that distribution or estimate the distribution of forces, or you have to predict the shape, how the shape would look like if there was no gravity. Let's say if the CT scans were taken in space. So we make a guess for that, what we call stress-free or gravity-free shape. And then through an iterative process, we can go back and forth while looking at the deviation between the real case and the simulation until the error becomes very significant, very negligible. That's when we know that we have predicted the right distribution of forces, or we have a reference configuration that we use to start off our simulations to predict shape in different positions. So here what I'm showing here is using that reference configuration, I'm showing how the breast would deform if the patient moves from supine position to upright position. So this is for that under gravity loading and upright position, moving the patient from supine to upright. So now we have a reference configuration that we can use to simulate the breast shape in different positions. So what we need is to further calibrate the model. We can use the tilt table system we have at MD Anderson, where we can take images of the breast at different positions. Then we can use it in comparison with the simulation results we have from our model in order to fine tune the parameters of our model. So here, what I'm showing here is a comparison between the 3D images obtained from the tilt table and the simulated shapes for two patients at two different angles, at 45° and 90°. So the blue surface here represents the simulated results using our biomechanical model. So as you can see, our model predicts to a large extent the breast shape at different positions, with maximum differences, especially for big breasts near the lateral and near the medial side, is about 5 to 7 millimeter. So in summary, we have developed a biomechanical framework that is able to predict breast shape change at different positions. And simulation results show that the proposed biomechanical model reasonably predicts the 3D shape under different loading conditions. So currently we are working on refining the biomechanical model by taking into consideration heterogeneity of the breast tissue. We are also working on conducting a mechanical test to characterize elasticity of other breast tissue. With that, I would thank you all for listening. Thank you so much.
Thank you so much, Mason. That was very interesting. Our next presentation is from Dr. Marquez, and she'll be presenting the effect of insurance payer and type of outcomes and readmission rates in patients undergoing breast reconstruction. And this paper, again, is from Stony Brook.
Mazen, if you can just hit stop share.
Yeah, I did. Thank you. Sorry.
Great. Thank you.
Hi, again, my name is Jocelyn Marquez. I'm general surgery resident at Stony Brook University Hospital. And thank you for the opportunity to present this work. We have nothing to disclose. The implementation of the Affordable Care Act has significantly increased the number of enrollees in federally funded insurance, government payer insurance programs. The Center of Medicaid and Medicare Services, however, have many quality metric and criteria for reimbursements for providers. Some of these programs include the hospital readmission reduction program, outcomes related to morbidity and mortality, as well as complications. Many studies have evaluated in other specialties the outcomes of patients regarding general surgery, urology, and breast cancer, regarding disparities between government payer insured patients and private insurance. However, many of these studies are limited by the number of postoperative days they follow the patients, limited up to 30 days. The purpose of this study is to identify potential differences in outcomes between breast reconstruction covered by government versus non-government payers up to 90 days postoperatively. The Cerner Health Facts database was queried using breast reconstruction IC9 codes between 2000 and 2017. Patients were stratified into 4 major insurance categories: Medicare, Medicaid, private, self-pay / uninsured. Data on demographics, surgical complications, readmissions were analyzed up to 30 days and then between 31 and 90 days. Total of 10,153 patients were included in our analysis. Mean age was 50. Majority of our patients were female. The breakdown between insurance groups include 7% Medicaid, 11% Medicare, 6% private, and 19% self-pay or uninsured. Our analysis determined that patients who, when compared to private insurance groups, Medicare and Medicare patients were more likely to develop bacterial diseases. And compared to uninsured patients, Medicare and Medicare patients were also demonstrated similar trends. This is also seen with cellulitis. When categorized into government versus non-government groups, the trend was similar regarding bacterial diseases and cellulitis outcomes. With necrosis, this trend was seen when the categories were government versus non-government. And when comparing any or looking for any complication between the groups, Medicare patients compared to private, Medicare patients compared to private, Medicaid patients compared to uninsured, and Medicare patients compared to uninsured all had higher risk of developing any complication after breast reconstruction. And when they were categorized into discrete government versus non-government payer groups, the trend maintained. When looking at readmission rates for these patients, Medicaid and Medicare patients were both most likely individually compared to private patients to have a readmission within 30 days. And same was seen when compared to uninsured patients. For readmissions between 31 and 90 days, Medicaid patients versus private were more likely to present for readmission. Compared to uninsured, Medicaid and Medicare patients individually were more likely between 31 and 90 days. And when categorized into distinct groups of government versus non-government payer patients, the trend maintained for 30-day readmission and 31 to 90-day readmissions. So in conclusion, there are a number of outcome disparities in breast reconstruction when controlling for insurance payer type. Patients with government-funded insurance are more likely to experience surgical complications and readmissions within 30 days, as well as up to 90 days post-operatively, compared to patients with other types of insurance. We do recognize limitations to our study. For example, the oversimplification of the insurance categories, including combining the self-payer and the uninsured groups into one larger group. Unfortunately, our study does not take into account the influence of socioeconomic status and access to healthcare services. And lastly, any patient who may have sought postoperative care outside of the certain institution was missed data and could not be analyzed. These are my references. Thank you for your time, and a special thank you to the research team for this project and Dr. Khan for his mentorship. Thank you very much.
Thank you, Dr. Marquez. Next, I'd like to invite Priya Chikara to speak to us on predictors of infection in mastectomy flap erythema following mastectomy with immediate tissue expander reconstruction.
Priya, we're not hearing your audio.
Oh, I'm so sorry. Let me try again. Sorry.
Do you have the box on the bottom left checked off to share computer audio?
Yes, sorry about that. I've totally.
No problem.
1 second. Okay. Trying again. Okay, got it. Hello, my name is Priya Shikara. I'm a PGY5 in general surgery at Mercy Catholic Medical Center. I'd like to thank you for the opportunity to present my abstract, which is affiliated with the Plastic and Reconstructive Surgery Department at Cooper MD Anderson, and is entitled Predictors of Infection in Mastectomy Flap Erythema Following Mastectomy with Immediate Tissue Expander Reconstruction. Hello, my name Postoperative erythema is a commonly encountered condition and can be attributed to many different etiologies ranging from infectious to purely inflammatory and non-infectious, which of course includes reactions to foreign materials frequently used in reconstructive procedures. The existing literature contains many reports regarding surgical site infections following tissue expander reconstruction. However, these studies are not sufficient in accounting for erythema due to infectious versus non-infectious inflammatory processes. In patients with a history of breast cancer who have gone mastectomy with immediate tissue expander reconstruction, postoperative erythema alone often cites concern for infection. This can lead to overtreatment with readmissions, a long-term IV antibiotic use, and reoperations with tissue expander removal, all without true evidence of infection. These infection control measures can create significant morbidity for the patient and have significant financial implications for the patient and healthcare system. With this study, we aim to define the criteria for assessing infection in patients who present with erythema following immediate tissue expander reconstruction by determining specific combinations of factors that differentiate erythema associated with infection from non-infection. Using the electronic medical record, we identified patients who had undergone mastectomy with immediate tissue expander reconstruction from January 2014 to December 2016. Of particular interest were the patients who developed erythema within the first 12 months postoperatively. Infection was further determined by positive cultures which were obtained from drainage or aspirate. We analyzed variables which were of primary interest, which correlated with the CDC's definition of surgical site infection in the presence of implants and included fever with a temperature greater than 38 degrees Celsius, elevated white blood counts, drainage or wound dehiscence, and localized pain. These primary variables of interest along with erythema were analyzed alone and in the combinations listed below for patients with and without proven infections. The correlation between these variables with the presence or absence of infection were then reported. We found that 38 patients presented with erythema. All 38 patients underwent further intervention with antibiotics, aspiration, or operation. 47% of these patients had culture-proven infection. Pain alone was present in 67% of patients with infection and 20% of patients without infection, and was significant statistically in predicting infection with an odds ratio of 8. Pain in combination with other factors was also statistically significant in predicting infection. Table 1 represents the variables with statistically significant predictive values for infection. Table 2 represents our data on the variables with statistically significant odds ratios for infection with erythema. In conclusion, while fever, elevated white blood count, and drainage and/or wound dehiscence were not found to be significant predictors of infection in patients presenting with postoperative erythema, these variables were more frequently observed in the infectious group versus the non-infectious group. Pain alone or in combination with other variables in erythema, as well as the combination of fever with an elevated white blood count, most reliably served as predictors of infection in breast cancer patients presenting with erythema following mastectomy with immediate tissue expander reconstruction. These combinations of factors, when observed along with erythema, may offer assistance in determining when further intervention is necessary in this patient population.
Thank you. Our next presenter is Helen Zun. She'll be presenting on the topic of the great cosmetic versus reconstructive debate, public perceptions on breast reconstruction as compared to breast augmentation and gynecomastia reduction. And this seems like a from the Johns Hopkins University.
Thank you so much to PSRC for the opportunity to present tonight. So here are our disclosures. So our study was inspired by a 2014 report that the public ranked plastic surgery lowest of 30 specialties in terms of importance in providing care for patients within the hospital. These findings are within context of the literature reports that the public are often only exposed to a very small part of plastic surgery practice. What the public is often exposed to on social media or media focuses on the cosmetic aspect of plastic surgery, which is very important, but not entirely representative of the wide breadth of practice. We know that plastic surgery encompasses more than that. Every procedure and every surgery is a harmony of form and function that results in a positive change for patients. So how can we start communicating and educating the public on the entire breadth of the plastic surgery field? We wanted to study whether or not linguistics or how the patient narratives are presented and how we describe the procedures can translate and impress the important values of plastic surgery to the public. To do this, we distributed a survey on Qualtrics to laypersons on Amazon Mechanical Turk. We showed them preoperative and postoperative photographs of breast procedures and captioned them with either reconstructive cues or cosmetic cues. Cosmetic cues focus on the cosmesis of the procedure. So for example, a breast augmentation to achieve a fuller breast size. The reconstructive cues focus on the function and improvements in quality of life. For example, reconstruction following a lumpectomy. So we know that all surgeries are actually a blend of these two, but for the purposes of this study, we separated them. We then asked the respondents to categorize the procedure as either cosmetic or reconstructive, willingness to pursue, and insurance coverage. We generated 459 responses. The mean age was 38.5 years and was 50.5% male, which is fairly representative of the USA population. For reference, USA population is 49.2% male with a mean age of 38.4 years. So here are some highlights of the study. We presented a breast procedure and cued it cosmetically as a breast augmentation, or we cued it reconstructively as a breast reconstruction following lumpectomy. The public voted more likely to pursue the breast reconstruction and more likely to support insurance coverage for breast reconstruction. However, we were surprised to see that only half of the people would pursue a breast reconstruction if they were in the same position, and support for insurance coverage was just under 3/4. We then asked the public to vote whether or not the procedure was cosmetic or reconstructive. So 90% of the public voted that the breast augmentation caption case was a cosmetic procedure. What was really surprising, though, is that when we asked about the breast reconstruction case, the majority of the public actually categorized breast reconstruction as a cosmetic procedure. So this demonstrates that there remains persistent public misconceptions of breast reconstruction, potentially undervaluing the procedure due to its focus on cosmesis rather than reconstruction. So conversely, we also looked at breast reduction for either solely cosmetic reasons for a lift or reconstructively cued to reduce symptoms of macromastia, such as to reduce back pain. Approximately 2/3 of the public categorized the breast lift as cosmetic and pain reduction cued case as reconstructive. What's interesting, though, is that the majority of respondents supported the breast reduction in both cases. Of note, 55.8% of the public also supports insurance coverage for breast reduction for solely cosmetic reasons, and 75.9% supported reduction if there were macromastia symptoms. So this is definitely a step in the right direction to help support insurance coverage for breast reductions for macromastia, regardless of indications. So lastly, in reviewing all of the presented cases, we found that the more likely the public is to categorize the procedure as reconstructive, the more likely they are to support insurance coverage for the procedure and willingness to pursue. And the p-value is less than 0.05 for both. So this indicates that the public does recognize the value and supports the procedures when we share the improved quality of life that result from the procedure. So what can we take away from all of this? The public does in fact support and value reconstructive procedures, but unfortunately misunderstands plastic surgery as solely cosmetic. So our study demonstrates that reconstructive cues or restorative cues communicate this value to the public, potentially more appropriately redirecting public perceptions to build a partnership between surgeons, patients, and the public. A limitation of this study is the usage and generalizability of USA and Amazon and Mechanical Turk as the USA public. However, many studies have demonstrated that the Mechanical Turk can be appropriately used for medical research. Nevertheless, the value of this project is to produce preliminary data for hypothesis generation on improving public value of PRS. Future work examines public education of the wide breadth of plastic and reconstructive surgery in practice, innovation, and research, and how this can add value and appreciation for the field. I would like to acknowledge our research team and PSRC for the opportunity to present our findings. Thank you very much.
Thank you.
All right, that was wonderful, Helen. Thank you so much. The last paper will be presented by Dr. Coquillard, and the title is Evaluating the Accuracy of 3D Automated Photogrammetry, a study of breast epimorphic measurements. And this is out of Case Western.
See if I can share my screen. All right.
Good evening, everyone. Thank you for sticking around for this last presentation of the evening. I'm talking about 3D photography for breast anthropomorphic measurements. And I am one of the PGY3 residents in plastics at Case. Oops, there we go. I have nothing to disclose. So for a bit of background, 3D photography has gained a lot of popularity recently in multiple plastic surgery applications, but it is most studied in the face and craniofacial surgery. Not a lot of studies as yet evaluating its use in breast surgery, and those that have been done so far have mainly looked at retention of fat grafting in the breast with volumetric studies. We also know that accurate and reliable breast measurements are critical for surgical planning of many breast procedures, such as reduction, lift, augmentation, and reconstruction. So the purpose of our study was to evaluate the accuracy of the 3D imaging system we happen to have at our center, which is the Canfield Vectra XT system in breast anthropomorphic measurements. And we hypothesized that there is no difference between the manual breast measurements we took in clinic versus those calculated using the Vectra camera and software system. So it was a small pilot study. We did a retrospective chart review of 11 adult patients undergoing breast surgery with a single surgeon. And we compared pre-operative anthropomorphic measurements using the Vectra system to those made by our senior staff surgeon in clinic. The measurements we compared were sternal notch to nipple, IMF to nipple, and breast width. We also took note of the patient's BMI, cup size, and ptosis grade. Then we used a T-type analysis to determine if the measurements differed. Sorry about that. So this is just showing the demographics of these 11 patients. As you can see, we had a pretty wide range. We had ages ranging from 20 to 70, BMI from 20 to 42, and a variety of ptosis and bra sizes. So I wanted to include some photographs of example patients just to show how the measurements are taken. This is an actual screenshot on the left here of the Vectra software and one of our patients. So once you upload the image into the software and it's stitched into a 3D image, you actually just have to hit 2 buttons for this measurement screen to appear. And I have on the right here a table demonstrating the measurements taken on this particular patient with the 3D camera versus manual. And you can see we have pretty good measurements, particularly for sternal notch to nipple and the breast width. Of note, the software automatically calculates breast volume, but we did not calculate that in clinic. And this is just another example, a different patient with slightly different habitus and breast shape. And in this patient, we have fairly good measurement accuracy in the IMF to nipple and breast width. For results, our measurements from sternal notch to nipple and breast width were not statistically different between the camera and the manual measurements made in clinic. However, the measurements from the IMF to nipple were statistically significantly different between those two. I hypothesize that this is because the software may have trouble placing where the IMF is. You can actually move around in the software where those landmarks are placed. However, to avoid any confounding or subjectivity in this study, we left those landmarks where they were automatically placed. So to summarize these results, again, no statistically significant difference between sternal notch to nipple and breast width. There was a difference in IMF to nipple. When we separated these into obese versus non-obese groups, however, the differences in measurements in patients that were obese in all measurements, the measurements did become statistically significantly different. And we also found that when the cup size was D or larger, the measurements were also statistically significantly different. So to conclude, automated 3D photogrammetry is accurate when you need a 1.5 centimeter or smaller error in surgical planning for non-obese patients. We do need to have further study to better elucidate the critical BMI where the accuracy falls within 5 millimeters to 1 centimeter to better predict surgical outcome. So a few future directions. This was a pilot study. I think we could increase our power a lot by having a lot more patients. We can also, I think, evaluate whether or not this is a useful modality in assessing breast volume, and also comparing different 3D camera and software options to see if, you know, one system would be more accurate than another. So I think, you know, those are a few questions to answer of whether we can do this. I think it's also important to ask, you know, whether we should use the fancy 3D camera for these measurements. And so I think it would be important in the future to evaluate whether these 3D camera generated measurements actually save surgeon time. I'd like to thank Dr. DJ Harvey, who was the PI who conceptualized this project, and April Adams, who was our clinical photographer. Thank you.
Great job. I think Kristen's going to lead off with some questions.
Yeah, sorry guys. My internet cut out. So I didn't, Michael, don't worry, you're not getting off without a question. So, you know, you talked a little bit about bariatric surgery and BMIs. So how much weight loss do you think is too much? And aren't we supposed to be encouraging that? And then also, did you look at vitamin D levels, and what are your thoughts on that?
So I don't have a number for too much weight loss, and I think that's something we could definitely look at in the future. I think more importantly, we'd want to definitely look at the preoperative labs, and you know, we didn't look at vitamin D specifically. I didn't have that available, and they weren't checked preoperatively for these patients, but hopefully we can see if there are labs done at Dartmouth Hitchcock maybe that were different than what was done at Mayo Clinic. I think also what's important is looking at, you know, the skin quality of these patients and really assessing them in the clinical aspect. You know, you can tell a lot about, I think, how a patient may potentially do in the postoperative period with the elasticity of their skin, if they already have lesions or, you know, intertrigo or rashes and other things that can kind of lead into bigger problems. So I think it really takes both preoperative evaluation in terms of your vitals, your labs, but also a good eye on the patient's body and the skin quality and the other issues that they may be hiding underneath, you know, skin folds and other concerns like that.
Great. And then I had a question for Jocelyn on the ALCL talk. So, so we're sort of taught to think about a problem with a textured device, getting an ultrasound, if you see fluid, do an aspiration, but your thought is that this was systemic ALCL. Do you have any explanation why there was really nothing involving in the flap? Do you think this was potentially a complete pathologic response and that's why you didn't have anything in the capsule? Or tell me a little bit more about how you hypothesize this makes sense.
So some of the theories we thought about is perhaps maybe she had really small amounts and that she had chemotherapy prior to surgery. So perhaps the chemotherapy addressed the microscopic cells that may have been that would have been captured on a specimen otherwise. Another thought was perhaps, like I said before, the systemic ALCL led to like a inflammatory response around the implant, but did not present the classical way you expect for BIA-ALCL. I know recently there was a paper, I believe last year, that discussed when examining the pathological specimen of the capsules to at least incorporate at least 12 sites of the specimen to make sure that, you know, 95% confidence interval that the entire most of the capsule was evaluated. And so we're in discussion with our pathologists to make sure that was done prior to us being able to publish this paper. So unfortunately, we don't have a clear-cut answer exactly, you know, whether or not did she have BIA-ALCL completely, but it went away with chemotherapy, or was it just strictly systemic response to her systemic ALCL? You know, it's a little unclear, but from what we can tell with the data and the pathology and cytology we have, it didn't sound like she had it.
Okay. And then lastly, I have a question for Priya. So I really like that because I think all of us have had the call about the red breast, or a patient send us in a photo or something like that. So if I have a patient with a red breast and she has no pain, no fever, no elevated white blood cell count, what do I do with her? Do I just send her home?
I think it also depends on what other circumstances are going on. Like we've seen patients that have undergone radiation treatment and then come back and had erythema and been totally unrelated to infectious causes. So you also have to consider if there is another type of reaction going on. If there are no signs, hard signs of infection though, I do think that with this research, you can probably start implementing a type of algorithm where you don't need to send people home with antibiotics. You don't need to start trying to tap or drain any fluid collections that you're seeing. And yeah, we were actually hoping to expand and try to get a bigger patient population. And hopefully that would be able to give us better numbers and be able to show what's actually more significant.
Thank you. It's a good area of interest.
Thanks.
Okay, so I've got a question for Jocelyn. So why did you use the Cerner database? And do you think that this had any factored into the discrepancies you saw between the Medicaid, Medicare, and the commercial insurances?
So Cerner Health Facts database is like a de-identified HIPAA compliant health record. Our hospital at Stony Brook is a Cerner powered chart organization. And so I believe members who are part of the Cerner, who use Cerner as part of the EMR have access to the Cerner Health Facts. I believe non-members can also apply for access to it. Essentially, there's about 63 million patients in this database. It began about in the year 2000. So between the year 2000 and currently, it's a longitudinal data set. And about 600 hospitals across the country participate. And so we, as a member, we're able to pull de-identified data from this massive database, and it provides us with outcomes as long as the patient presented to a Cerner institution or within the Cerner umbrella. We're able to track their outcomes postoperatively. It's not limited to just surgical procedures. It can be also medical patients or other types of diagnoses. In terms of how it may have affected the discrepancies we've seen, we're gonna have to do a little more digging to see exactly, we can't tell exactly which hospitals are involved in this data set for Cerner Health Facts. So if a hospital is less likely to allow patients with government payer insurance to have procedures there, or hospitals that only take private, things like that, those details will have to be teased out a little bit more from our end. But I mean, 63 million patients, I think it's a pretty robust data set for us to use through this project.
It's definitely a large data set. Kristen, so you've shown that a tape measure and a marking pen is just as effective as probably a pretty expensive piece of equipment. So what should we do with these 3D imaging systems? Is there a role in, or should they be in the armamentarium, or should they be in the, in the Smithsonian?
I do actually think there is a role. I think, unfortunately, one of the parameters that I didn't include in this study was breast volume, because we don't measure volume in clinic, but I do actually think that's going to end up being one of the more useful measurements that's taken by these 3D cameras, especially for patients who, undergoing reconstruction, want to remain a similar size, or want to say I want to be this much larger, et cetera, because it does give you volume, and then you can sort of appropriately have your think about how much you want to expand them or what you want their final implant size to be. You can also, or I think with the breast, although a tape measure is equally as effective, kind of predict what implants you want in the room. you know, I wonder if in the future it might be useful to use volume as something to be able to submit to insurance companies for patients with macromastia that want to undergo breast reduction. And then there is the question of, will it save time? We have actually started timing our clinical photographer versus our attending. I don't have those results yet, but I think it will be interesting to see. And one other thing that is generated by this software that I didn't include is a really nice printout that you can give to patients with, these are your measurements. This is what you look like pre-surgery. And you can very clearly see, especially with measurements, asymmetries pre-surgically. You know, one of the things that is difficult with breast patients is they'll come to you after surgery and say, oh, I'm asymmetrical. And it can be difficult to have the conversation that they were asymmetrical to begin with. So.
All right, I think I have a few questions. So Mazen, thanks for a great presentation. I love the idea of decision support systems for our patients who are undergoing breast reconstruction. The question I have is, it sounds like you're trying to predict outcomes to help patients make a decision. But I think it'll be tough to have a simulation system that accounts for the surgeon factor. I think surgeons play a big role in the results that are achieved. And so predicting what the breast would look like and trying to help a patient make a decision, is it possible that we maybe giving them information that might be leading them down the wrong path? Or is it possible that we might give them information and they might be disappointed after we don't deliver what the simulation shows?
Yeah, I guess it's possible. I mean, it all depends on the experience of the plastic surgeon at the end. I'm not a surgeon myself, so but I know that it depends on the experience. So the model now, it doesn't really take into consideration the experience of the surgeon. It's mainly based on the data we obtain for the patient and what type of construction the patient decides to undergo. So probably in the future, I am not sure at this moment, but yeah, that's a good question.
No, it's just I guess the art part of plastic surgery as opposed to maybe the science. But
yeah.
no,
So at one point, probably for using the model, probably you can predict what could go wrong if you opt to take one direction or the other. But yeah, I mean, there are more factors to consider, I guess, to take into consideration the experience of the surgeon.
Right. Thank you.
Yeah.
And then I think Helen, I have one question for you. So I listened to your talk and I saw the surveys were sent out to the public asking questions about whether or not insurance should cover certain procedures. The question that I ended up with in the end was, do you really want insurance paying for cosmetic reductions?
Yeah, I think that's, there's going to be a lot of different opinions based on that, but we were really interested in just characterizing the public opinion. And taking that data to generate ideas of how we can move forward with that. The priority there was understanding how the insurance status could potentially correlate with the reconstructive versus cosmetic aspect of it, whether that makes a difference or not, and whether or not that actually correlates with the willingness to pursue and the values reflected in plastic surgery. So it's a very good question that I think we need to study in the future. And but at this point, we don't think there's enough data on public perceptions and landscape surrounding public opinions to make the decisions that we need to. Yeah.
Okay, thank you. Very nice talks, everyone.
Thank you.
Are there any questions from the audience? Anybody who has any final questions? So I have to say that these last 2 weeks with these 4 breast sessions have been really wonderful. I've learned a lot. I really appreciate all of our speakers today. You all are the future of plastic surgery, and I have to say that the future of plastic surgery is in great hands. And I look forward to hearing all of you at future meetings with the research that you're doing. I especially want to thank our moderators, Drs. Broderick, Otterburn, and Momo. Once again, to Brian Gassman from the PSRC, the chair of the PSRC. And I really do hope that we can all see each other in person at the meeting in Cleveland in May. And another big shout out to April and all the people at PRI for putting these all together. And I do have to say that the thing that I probably miss the most from in-person meetings is getting together afterwards for some informal talks about plastic surgery, but also about other things. And this is our opportunity now. I hope all of you can stay on for another 20 to 30 minutes as we have a bunch of other faculty members getting on the call. And this is a chance for everyone to talk about what's going on with COVID and residency applications, fellowship applications, and get some advice from a variety of people in different stages of their career in different parts of the country. And I do hope that you'll stay on for this great opportunity. Brian, do you have any last comments? I don't know if he's, let's see. Well, again, so thank you, everybody. We still are continuing, and Dr. Otterburn is going to be the MC for this time. And please, everyone, chime in with questions or comments. I know that one thing that came up, so that was the end of that part. So I'm moving on. So one thing that came up in the last mentorship session was that for me as faculty at a really great program, I was interested to hear what people have thought about the virtual meet and greets that we've had, and the things that people have liked or not liked about them, and things that you would like to tell us we could do better. Certainly you don't have to answer that, but just as a way to start things off.
Are there any applicants on the call?
Yep, I see some hands. Or a hand. No pressure if you don't want to speak up, and if you have questions about other things as well.
Hi guys, my name's Avra. I'm an applicant this year. I'm a 4th year at Harvard. I think the virtual meet and greets have been great for us to get a sense of what programs have to offer. I think the hardest part is getting a sense of that culture and that fit. But what some programs have been doing is offering smaller sessions or breakout rooms for applicants to meet their residents and their faculty. And that has been a great adjunct to the meet and greet PowerPoint slides.
Good. Have you felt overwhelmed with the amount of, there's a decent number of programs, and then if each program has a couple of these things, it's you do actually have training and and work.
In short, yes.
No. Okay.
So I'll be applying for independent next year, but I was on the Best for Breasts PSRC mingle last week, and what I thought was kind of refreshing was being able to, kind of talk to, all the PIs, investigators, and attendings from other institutions. And what I found at in-person meetings, if I see a investigator that I'd like to talk to in person, you get a little nervous wanting to talk to them in person. But I think these virtual meetings make it more open to be able to have a conversation with multiple people, and takes a little bit of the nervousness out of the equation, which is nice. So I hope it's the same for the applicants who are going to the meet and greet.
Hi, I'm Helen from Johns Hopkins. I'm applying this fall as well for residency programs. I think in this time and age of technology, you can be multiple places at once, and you can talk to people through multiple mediums. And so for us coming from the East Coast, we have a great network to tap into through NESPS, through our mentors. But I do worry a little bit about my co-applicants who might come from smaller schools that don't have plastic surgery programs, and that there continues to be an unjust distribution of resources, and their biggest, cash cow or biggest token is attending these conferences and making those networks and building those networks, and they lose that. So I'm wondering if maybe there might be a good way to supplement this for all applicants by creating some sort of like mentorship buddy program to connect all applicants from around the country, or at least some sort of way that that we can make sure that the networking is evenly distributed for all applicants.
So if you didn't have a training program at your home institution, you were actually allowed to do sub-Is, which is supposed to sort of even the playing field a little bit, because there's nothing better than obviously a 4-week interview, so that you can get to really know an institution and know the culture and get integrated into that program for a short while. Because that is obviously is a huge problem. Unfortunately, though, there's some regional issues. Like in New York, we wouldn't accept anybody from from out of state. So it really kind of limited our ability to take to take sub-Is from places which don't have programs. Be interested if anyone has any of the faculty members on had sub-Is from institutions which don't have residencies. Did they get sub-Is from outside places?
Yeah, at Michigan, we were able to. We had one sub-I from a smaller program within the state that didn't have a plastic surgery program, so we were able to do that. But that's just one student for the entire season. And thinking about the mentorship piece, I don't know if I'm allowed to say this. ACAP's different organization did think of a way to pair up applicants from smaller schools who don't have plastic surgery programs or mentors with faculty across the country in a mentorship program earlier on this summer. I think a lot of the problem with this is how does the information get out and does everybody know about it, And so, but I think some efforts have been made to try to bridge the gap.
No, thank you very much. We are all very appreciative of the amount of time and thought that you've put into making this a good year for all of us, and we appreciate it.
I have another question for the applicants. One of the ways that we've done a lot of the outreach and even at our institution, how we're setting up logistically how to do these things is through Instagram. Are there other platforms that people are using that they find better for this? Does anybody else have any other tips and trips? I always worry about somebody who didn't have an Instagram account. And I remember that was my interview question for everybody last year was, are you on social media? And half of the people said no. I don't know if that's true or not.
They just didn't want you to check their social media.
I think this question is so important, and I actually, maybe I'm not supposed to say this, but I serve on the ACAP social media task force, and this was absolutely something we were thinking about when we were trying to decide what platforms that ACAP should be communicating information from. We ended up creating an Instagram and a Twitter profile, but it became very clear very quickly that Instagram was the media of choice for plastic surgery programs and for applicants, and our Twitter account is severely underused, which hurts me because I am a bigger fan of Twitter. But I think most applicants who are aware that programs are on social media are typically using Instagram.
So any thoughts about the application process and the actual interviews and those type of things? We don't have to talk all about this stuff, but I figured, that's probably on your minds. No, everyone's good. All right.
There are so many stressors that we could discuss. No, it's okay. I think one new thing this year was the common application, which is interesting, that some programs are piloting. We don't have to talk about that controversy, but it is something new and debated currently by the applicants.
Yeah, yeah. There's a lot of changes going on, basically in higher education across the board. You know, pass fail. You know, instead of having grades. You know, doing away with score. You know, looking at scores and standardized tests. And you know, the question is, you know, at a certain point we have to pick. You know, still pick people. And so, you know, how do you do that? And it's hard to really figure out what the, you know, I don't think anybody really understands what the best format is to get the best people, you know, trained so that they can be the best plastic surgeons and take care of us. You know, and so it's a really tough question to figure out, and we'll discuss it in 10 years and see where we are. But yeah, anybody else want to jump in that hand grenade?
I figure it's probably just a way to figure out how you deal with stress. You know, throw this your way shortly before your application's due and see how you handle it. So that would be my only response to that.
I do have a question for the faculty on the call, if I may. How do you plan to assess an applicant's level of interest this year? Typically, let's see if they try to do an away rotation with you. I think in addition to that, a lot of applicants feel like if they're not showing up to these Zooms or these meet and greets, that if their name isn't on the attendance list, it'll be construed as them not being interested and things like that, which I assume is not the case. But how do you guys intend to assess that?
Well, I haven't taken the attendance list from any of these meetings, so you can feel rest assured about that. I don't know if the other faculty member have, but I doubt that they have. I think it's more sort of your application and your maybe more sort of your commitment to the specialty. That, you know, if you've been, you know, as a program director, obviously you want people who are going to, you know, raise the level of your residency, and that's people who are committed to, you know, committed to plastic surgery. And so has that been shown? I mean, obviously people bloom late, and some people decide late that they want to do it, and they're going to be great candidates as well. But you know, I think your body of work in your medical school and the research you've done, and if you're presenting at conferences like this, or you know, that's what sort of shines through. But yeah, I mean, it's, you know, this is going to be a year that's going to be looked at and studied many which ways because of, you know, we're probably going to look at this next year and say, wow, you know, not having to pay an average of $13,000 to travel around the country to interview is fantastic. Maybe we should be doing this permanently. But the bottom line is, did we get, as one of you mentioned, you know, is it the right match? Is it the right fit? Do you feel comfortable with that program? And that's going to be really, you know, really hard to figure out. What do you guys think?
I think also, I think one of the things, David, I agree with that 100%. The other consideration is that everybody is in the same boat. And, you know, so everybody's doing the exact same thing, and we're all doing the best we can with these kinds of conversations. I mean, I'm trying to teach lectures this way, and hopefully people are getting it and understanding it, and we're all doing the best we can. You know, it's going to be a fit thing. And at the end of the day, it's, you know, it's weighted in favor of the applicant. So you do your best assessment of us as you can. And, you know, you'll find your people. I don't know how to say this, like, it's not that complicated. Just, you know, it's an interview, it's an application process. There are 100 different, or probably for you, there may be 10 really great choices. One of them's going to work out. And, you know, it's, I don't know. I think people are overthinking it because we're all sitting at our screens and we're having anxiety about stuff that doesn't matter because we don't have anything else to do. Just my thoughts.
Yeah, and I want to echo what Kristen says. I mean, yes, we always want to feel like we found our perfect match both ways, you know, that the student finds a place they were meant to be. But in reality, the plastic surgery training in this country is wonderful. And we've got many programs that maybe the personalities in the programs might be slightly different, but we all do a really good job of training plastic surgeons. And if you look at who passes their boards and who goes on to be a successful surgeon, you can come from pretty much any program in this country. And so at the end of the day, even if this process isn't perfect this year because we can't do it the way that we always have done it before, I think that ultimately people are going to turn out okay. And I think especially the people here who are clearly showing that their involvement and their interest and all those things, that at the end of the day, it's going to be fine. And we can train anybody. So we're happy to train anyone. And hopefully, you know, if you don't end up in the place that you thought you were destined to be, or even if you do, you'll have a great experience, you'll have great training, and you'll have the relationships that are going to propel you to your career, which is really what this is about.
Thank you. That's very reassuring.
So, any other questions? All right. Well, it's you know, it's almost 9:45 over here on the East Coast. So I think I'm going to say, hey, you know, this is Dr. Rohde. This was a fantastic evening. Thank you for organizing this. Definitely a round of applause, as always. You run a tight ship, and you did a fantastic job. And thank you to the 10 wonderful presenters. These were excellent papers. And well, actually, there was 9 presenters because someone presented twice. So, but yeah, congratulations, everyone. Joselie, that was great. So, okay, bye-bye now.
Good night.
Thank you, everyone. Have a good night.
Thanks, everybody. Bye.
Thank you.
Thank you. Night.